Okay. So we've got about 45 people joining us online, so that's great. Welcome. We're glad you're able to join that way. So, first question: when the new hospital opens, which sites will stay open and which ones will close? So, Cliff or Ron?
I'll address that one. So, when the new hospital opens, the St. Mary's site or the group Queens Boulevard will close, and all services will be moved into the new hospital. Midtown will stay open. It will still have an emergency department and patient, particularly the cancer mental health program will stay there. And Chicopee is our complex care rehab, specialized mental health. That will stay open. In fact, both those sites I mentioned before will actually be under development as well, addressing the growth in the community. So the only one to close is the Queens Boulevard site.
And for those that aren't aware, that site is actually owned by the St. Joseph's Health System out of Hamilton. So they will receive back that building and that site. And, they have been engaging with the community to determine its future, but that's not yet been determined yet. Okay. Yes, go ahead, sir.
Where will they go and will that be one surgery only, or will there be additional surgeries in the hospital?
So the question was about day surgery. Where will day surgery be offered? And would it only be at one site, or will it be at multiple?
The long-term plan, which includes the full development of the new university hospital as an acute site, would mean that the Midtown site would be the ambulatory facility where day surgeries would be. We're still quite a few years away from that. So right now, it will be split between the new hospital and the Midtown site, depending on the specialty that the surgeons are dealing with.
Just stick with the new hospital because we do have a few more questions. It's one we often get questions about. People are excited about it. That's great. How was the location chosen for the new hospital? And maybe just remind us where it is geographically and how it was chosen.
Actually, the new hospital location is just north of the University of Waterloo on Behringer and Hagee. It's right beside the Laurel Creek Reserve. Very beautiful site from that perspective. It's just north of the David Johnson Research and Technology Park. It was actually chosen through a very extensive process where an RFP went out, and it was supported by a site selection committee of 6 community members. The hospital itself, while we participated supporting that group, the selection committee, we did not participate directly in the selection. So it was picked by the community representation, which Carl Zara was the chair of that committee. They looked at, there were actually 2 stages. The third stage, or second stage, was when they had 3 sites in the submitted, and they chose the university site. One of the criteria was that it was 50 acres. And you could see by the diagram that's over there too, is that we are filling up that site very, very effectively, I would say. But there's lots of growth for the community. And that's one of the issues with the Midtown site. Queens Boulevard, St. Mary's site is a good example. We can't build on it. It's too tight. It's dense. We can redevelop it and we can be able to provide services. But for the future community, after 2050 and the 2080, and for our next generations, this gives the capability that we don't have to go through this exercise and move the hospital again. We can continue growing one site.
Yes.
And I think we against the rate of Michael. When you meet that capacity to 100%, where do you go there?
Great. Yeah. Great question. So just to repeat, in the new hospital, we have single patient rooms. So if they are all full, what do we do then? If we're greater than 100% occupancy, where do we put them?
So that's really, that's right. So the first thing is when we actually plan a hospital, so the new hospital, we only plan for 80% capacity. So we take what we think would be 100%, and then we put 24% of the rooms in there. And then this is very effectively something that Ron, as the leader brought, is that we're just not focusing on building the new hospital and then we're done and walk away. We're continuing to build. So that 20% theoretically should never fill up to the point where we don't have beds. Because we'll continue to build. There's another addition, phase 1C, which is going to be another 1 million square feet, which would have additional beds. So this is always a constant renewal of our facilities, but also the growth, and a very growing community from that point of view. I will also say at Midtown, where there will be some inpatient beds, what right now they're starting to double, and they're also 4 patients per room. You'll be able to provide single rooms there as well. So that's really important to the quality of care and the patient experience.
Well, because we still have the Midtown site, it is also the ability to actually get beyond 100%. We still have capacity because some of those beds will be moving to the hospital as well. When we first open the hospital, and then you continue to have that capacity still kept. Where's the money? Good question.
How do you finance the new hospital? Where's the money?
So this hospital, like any other large hospital in the province, is financed through 3 key areas, or 4 key areas. So the first and the largest is the province of Ontario. The province of Ontario covers 90% of the construction of the facility and all of the planning costs. And then there is what's called the local share that is made up of 3 key components. The first is a fundraising campaign through our foundation. The second is additional revenue that the hospital is able to generate from being in that new location. And then the third is through participation of the local municipalities and broader regional municipalities as well. Oftentimes, those municipalities use levies as
Go back to online, if that's okay with everybody, and quickly touched on this a little bit. The question is, will there be enough beds for our growing community? Will the hospital be the right size for the community by its next?
Yeah, so again, we're planning out using 2022 as our base year. We plan of 10 years plus another 15 plus another 20. And that's why we know what our capacity will be. So when we open the new hospital, we know that we have capacity for the 80% and the additional 20. And then we're planning for the additional beds after that. So from my perspective, it's a constant being recognized as the growth of the community. And one thing that I think is really important is that we actually go beyond just what the census is telling us. When we start to look at redevelopment, number of building permits, what's happening in the community, what's happening outside the community as well, and planning the beds from that perspective. The government does have a lot of control over the number of beds we get, but from my perspective, we're always planning to exceed what we need for delivering care.
Yeah, and, I think it's a great question, right? We have enough beds, we have enough beds. What I would also add to this discussion is, and it's the theme of our strategic plan, Care Reimagined. So we really think about care in the future as how do we deliver more of it at the point of need, as opposed to people always having to come to hospital. So an example, this past year, we have a program that's called Hospital to Home. So where people traditionally would maybe have stayed 2 or 3 days longer in hospital, we're actually able to get them home now with our community partners to be able to deliver care in their homes. What we're now exploring, and it is being done in other parts of the world, is hospital pathway. So if I come to the emergency room today, be admitted to one of our medicine beds. Under this program, under the right parameters, we would admit you to your own bed at home and make sure that we wrap around with our community partners and others to give you the care that you need. So it's not all about just build more beds. It's also about how do we reimagine care and think about the community as our campus of care, not just university campuses.
Happy, did you want to add in, you've been an instrumental partner in some of the supports to get people back home safely. Did you want to add?
Well, I would just add this, part of it is also thinking a bit upstream. So some of the work that we've done to work with primary care, and when people are coming into the local primary care offices, are there things that we can help them with that they may not need to go to hospital? That we can keep them well and supported in the community. So that's one hand. The other piece is there's been some fabulous work happening around the whole transition from hospital to home. So beyond the hospital to home program. As an example, this past year, we brought over 2,100 patients from hospital to home and supported them to stay for the first 6 weeks. And we know that conservatively, we save 40,000 hours of hospital stay. And so trying to sort of figure out what is the right place for people to be cared for, how do we work that? So it's not all about staying in hospital, right? It's how we can get you home around those.
Saw another hand go up during the conversation. Yes, go ahead.
Still not.
So the question is specifically about women and children's care first. Will they still be delivered in hospital? Will there sort of be the next level down care for babies that are born in the region? And we know sort of the projections, we keep expecting to see more.
So I would say over the next decade, 15 years, we're going to continue to see a ramp up in the number of births that are occurring in the region. I think the question about where those births will occur is a great question. We're already seeing less births in hospital as a percentage than we did 5 years ago, 10 years ago. We know we still have a very young population. We know we're still a region where many newcomers to this country arrive, and they're as well. So I would anticipate that we will continue to see that increase. We're planning for it in the hospital. We're planning a larger neonatal intensive care unit as well. And we already have a very active midwifery program at the hospital, and I would expect to know that too.
We'll go back and got a few more questions from one. Doug, this one is for you. How do I sign up for the Red Day Walk?
Yeah. So redday.ca. Very simple, redday.ca, and you can sign up, bring your family. And we have a number of stops on the route from uptown to downtown, including one at Midtown campus of REC. So great activities with kids and all.
And that's this Saturday.
Yeah, this Saturday.
Okay. Any other questions in the audience? Okay, this one might be a little triggering for folks who've been here in 2020 or 2021, 2022. How is the hospital preparing if there is another pandemic?
Well, I think it's a great question, and I would expand it beyond the hospital. So it's like, how is the community preparing? I think we've done a reasonable job of taking the lessons learned from last journey through COVID and responding together. From a hospital perspective, we have retained phone. So it'd be much easier to go into action as opposed to go construct. I would say that our infection prevention and control practices that we, through support of the provincial government, with additional investments in infection prevention and control hubs. So the hospital operates a hub that supports a broader. And I think we haven't talked about it yet, but one of the bodies that brings a lot of organizations in health and social services together that will play a role in well, the last one is our KW4 Ontario Health. And I think that it has strengthened its capability to respond to the.
Can I add to that? Because this is actually very exciting. Remember I talked about the fact that we have to build this hospital in 2 phases. The proposal we have in front of the ministry now says that the first phase will be open and operational about 2 to 3 years before the second phase. When the second phase is open, we'll have a full hospital. But in each phase, there is inpatient beds. And if you can imagine, if you could take the hospital and cut it right in half, that's what we're doing. When it's done, it'll operate as one hospital. But the amazing thing here, and this will be a first, probably, if not for Canada, for North America, is that it can be operated as 2 different hospitals. So one of the problems with COVID was we didn't isolate all the COVID patients, so surgery started to stop. But we can actually isolate the one hospital to be a COVID hospital. The second one can still function and be offering services like surgery and cardiac. Because that was one of the biggest issues with COVID was that cardiac patients weren't going to hospital because they were worried about getting COVID. The one thing about the new hospital is that we can separate them so they're completely, from an air quality point of view, from an infection prevention point of view, can be separated. So we can be fully functional. And that's really exciting. That's a byproduct of the government saying, well, you have to phase the project. Well, we heard that. What might could be seen as a negative into a real positive, being one of the first ones in, again, I would argue North America to have a really an effective prevention protocol, or if we ever have an outbreak of some type of COVID again or something else. So very exciting for that.
Back to the discussion about single rooms in the big hospital. Recently, audience here when you have those types of designs. So we'll just keep getting better. One more on the line. Certainly, we've got the right people to get care, primary care, hospital care, building. Okay. Are there any others online? Okay, the last one. Let's come in then and maybe we'll end on this. And I'm feeling Ron, you went bounce this one back to me. So why did you decide to change your site?
Go ahead.
Take it. So so the legacy staying areas, General Hospital and Brandon Hospital. And of course, people still refer to the legacy. And to be honest, I think that will happen for years, decades, maybe generations. I think, I forget which presents we refer to legacy Brandon PW Hospital. So we do continue to hear those things. It's a while to change it. We expect that. But certainly what we were aiming for, what our board supported, was a new organization where everyone needed to be one, regardless of which site you worked at. You were part of the Waterloo Regional Health Network. The other question we had is why not hospital? Why health network? And that was very intentional to be inclusive, to think about what else could we do in the future that wasn't traditional. So it leaves the door open, leaves possibility open to be even more inclusive in health services we offer. Waterloo Regional also is owed to the stretch of our regional programs and really how far away we have patients come to visit us. And so it is intended to be a very inclusive need and to bring everybody to that one that anything you want to two more questions. Good.
Just to say that, very pleased that you know how this is about this. Starting. Well, or better from it. Yeah. We know. There is an additional patient that they can privately build. So that is a great thing. If you own a long-term care facility, that's the structure. And it's. That are in existence, moved into the facility, there's serious space available for healthcare related kinds of activities. There are other things that come up. Sure, I don't think I can. Things within the system. Well,
We're glad to be here. Glad to hear well, and we know Stephen Harrison from you, and so we'll stay connected. It's very important help here for sure. Any comments, maybe those that are just about your presence here and the importance of partnerships?
The collaboration with the community is just so critical, and care does end at the hospital. And I think just so pleased that there has been the interest in engaging with the community and gathering the feedback, and how do we leverage the wonderful connections across the community to the caring the vision program. Lots and lots of potentials. And I think it sends a very strong, I have to say personally, it sends a very strong message that as part of the engagement, you're out in the room, right? Looking at ways to
And then I want to thank you as well, Ben, and Woolwich Community Health Center. As you saw in this presentation today, there is great expansion of care for more attachment of patients to primary care. And so, we're really grateful for your leadership out in the attachments as well. There was another hand that was on. Oh, sorry, yes.
Just wanted to tell you, thank you. Also, thank you very much for coming tonight for your time. Both my husband and I, on more than one occasion, have gone into Midtown, carried it, and we walked out. And we're very, very grateful for everything that you've done. Thank you very much.
Okay, thank you. Yeah, there's some great people there. Take care. Yeah. We did get one more from online. What are the main needs for improving healthcare in the region? And what advice do you have for those entering healthcare and how they contribute? So where are the greatest needs regionally in healthcare? And for those that are entering, where do we advise they go where they can really make a contribution?
Entering professionals.
I think that's the way it reads, yeah.
So greatest needs right now, when I think of on the physician side, we still continue to need, and I shouldn't say physicians, I should say primary care providers. There's still primary care providers. So that would always be an area that I would see more and more people to, because it is the key to staying, which is the key to reducing the demand on other parts of the health system. When I think of other parts of the health system, I think about anesthesia, I think about neurology, I think about neurosurgery, and I also think about how the practice of healthcare delivery is going to change with technology and artificial intelligence. So what I would say to people who are just thinking about it now is don't think about the traditional way of delivering medicine. Think about medicine in AI world, how you will gain all of those skills, become
Others?
Just to build off what Ron had mentioned, many folks don't realize there are 70,000 people in the region without access to primary care. That's a tremendous number of people who are probably accessing service in the hospital, and they don't need to be in the hospital. So exactly, please, whoever's online, who's asked the question, primary care, absolutely, we'll take you. But primary care isn't just providers. Primary care is community outreach, it's system navigators, it's dietitians, it's that wraparound support, that prevention piece to keep you healthy and well so that you don't end up needing acute services.